Hello, I'm Fred Masoudi from the University of Colorado. I had the pleasure of moderating a late-breaking clinical trial session entitled Medical and Surgical Advances to Improve Patient Outcomes in Heart Failure. We had a number of very interesting and provocative trials that were presented today, and we're going to talk about 3 of them now. I'll start with Dr. Anthony Tang, who will talk about the MINERVA trial.
My name is Anthony Tang. I'm from the Western University, London, Ontario, in Canada. I have the privilege to discuss the MINERVA trial. This is a trial to look at the different types of pacing modality in the effect to reduce the atrial fibrillation burden, particularly the development of permanent atrial fibrillation, mortality, as well as cardiovascular hospitalization. This is a trial that included over 1,100 patients, and they show that with the combinations of aggressive atrial pacing and minimizing ventricular pacing, we're able to reduce the atrial fibrillation burden and patients' development of permanent atrial fibrillation. So let me give you a little bit of a background. The background is that from many years ago, the observation is that many of the patients who develop atrial fibrillation seems to occur when it was initiated with premature atrial beats and in a slow heart rate situation. So therefore, the idea was to develop algorithm to be able to speed up the atrial heart rates and be able to eliminate these pauses. And the algorithm has been demonstrated to be very useful in eliminating the premature atrial beats and increasing the atrial heart rate. But in the past, this was also coupled with a increased ventricular heart rates, ventricular pacing, particularly from the right ventricle. And lately, it has been demonstrated that this particular secondary effect has been detrimental, in fact, increasing heart failure and increasing atrial fibrillation itself. So subsequently, a newer development to minimize the pacing in the ventricle and coupled with an increased atrial pacing, and that's what this study has demonstrated. And it is effective in doing so and effective in reducing permanent atrial fibrillation. The question now is that should we be utilizing this type of technology in these type of patients with sick sinus syndrome with paroxysmal atrial fibrillation in the onset? We probably need a little bit more data. Particularly, we would like to know the cost effectiveness of this therapy, and we would like to know a little bit more about whether it actually reduces other clinical outcomes such as stroke and atrial fibrillation related hospitalization. With this further information and perhaps subsequent studies in this nature, perhaps it will change the way that we deliver this pacing therapy to this type of patients.
Thank you, Dr. Tang, for that interesting discussion of the MINERVA trial. Now I'll turn to Dr. Tim Gardner, who's going to talk to us about an NHLBI-sponsored trial on surgical approaches to ischemic mitral regurgitation. Dr. Gardner.
Hi. I am Tim Gardner from Christiana Care in Delaware and Jefferson Medical School. I was the discussant for the clinical trials, the Cardiac Surgery Clinical Trials Network sponsored by NHLBI. And we looked at a population of patients requiring surgery for severe mitral regurgitation. So these are patients who had functional or ischemic mitral regurgitation, not patients who had primary valvular cause for the regurgitation. And this is a group that has not been well studied, and for whom the option of treatment was either repair, which is done more often in cases of mitral regurgitation, or replacement. The 12-month results were perhaps somewhat surprising in that it showed that chordal sparing mitral replacement was just as good, in fact, and perhaps in some ways even better than repair, which is the preferable form of dealing with mitral regurgitation today among U.S. surgeons. Specifically, the surrogate endpoint of reverse remodeling was not different in the patients who had repair or replacement, and none of the clinical outcomes, that is MACE or serious adverse events, were different. However, there was a 30% plus incidence of moderate to severe mitral regurgitation recurrence at 1 year in the repair patients. So despite the fact that the clinical outcomes were not different, the repair group ended up with a significant incidence of regurgitation. So I think the conclusions at this point from the study, which will be followed for another 12 months, is that in fact, in these patients with functional ischemic severe mitral regurgitation, valve replacement, when it's done with a cord-sparing technique, is equally effective to mitral repair, which, as I said, has been the preferred option. What is especially notable is this somewhat unexpected occurrence of recurrent mitral regurgitation, which clouds the results for the repair patients, and I think deserves a careful follow-up in the next 12 to 24 months.
Thank you, Dr. Gardner, for that discussion of a very important surgical trial. I'd like to also introduce Marco Metra, who is another discussant who has joined us here today. But before Dr. Metra speaks, I'd like to turn to Maggie Redfield from the Mayo Clinic, who's going to tell us a little bit about the TOPCAT trial, a very important, again, NHLBI-sponsored trial in heart failure with preserved systolic function.
Thanks. The TOPCAT trial was a trial of a mineralocorticoid receptor antagonist, spironolactone, in patients with heart failure and preserved ejection fraction. The rationale for this study was that this class of agents in patients with heart failure and reduced ejection fraction markedly decreased event rates, heart failure hospitalizations, all-cause mortality, and all-cause hospitalizations. So data also in human and experimental HFpEF supported the rationale for testing this class of agents in HFpEF. The study population consisted of about 3,500 patients enrolled across the world who had an ejection fraction less or greater than 45% and either a history of a heart failure hospitalization or, if they hadn't been recently hospitalized for heart failure, an elevated NT-proBNP level. The primary endpoint in this trial was a composite endpoint of cardiovascular death, heart failure hospitalizations, or aborted cardiac arrest. The follow-up in this study was an average of 40 months of follow-up. So what were the findings? Well, there was a trend, but not statistically significant, in reducing the primary endpoint. They looked at a large number of secondary endpoints, including all-cause mortality and all-cause hospitalizations, and these were not significantly different in the spironolactone-treated or the placebo-treated patients. But they did some really important subgroup analysis in this study. And they found that sites from some regions of the world enrolled patients that seemed much less high risk. And this seemed to potentially influence the findings of the study because other sites where the placebo patients had poor outcomes, the drug seemed to work in those centers. But in the centers where the placebo event rates were very, very low, there was not an effect of spironolactone. The other important subgroup analysis they did was they looked at patients who were enrolled into the trial because they had a recent heart failure hospitalization versus those who came into the trial because they had an elevated BNP. And again, there seemed to be a much stronger evidence of benefit in those patients who were enrolled with very firm evidence of heart failure as indicated by an elevated BNP. So what is the implications of this trial? Well, there was clearly a signal of benefit. When they looked at the components of the primary endpoint, there was a significant reduction in the number of heart failure hospitalizations in patients who were treated with spironolactone. And importantly, when they looked at total heart failure hospitalizations over the duration of the trial, there were fewer heart failure hospitalizations when you included multiple hospitalizations in patients treated with spironolactone. So that's a really important finding. However, the global public health impact of this therapy in this specific trial population is less clear, because all-cause mortality and all-cause hospitalizations were not reduced. But the trial definitely suggests that this drug may have a role in heart failure and preserved ejection fraction, but clearly more studies are needed to figure out which patients would most benefit from this class of agents. Lastly, safety with these agents is always a concern, and there were more episodes of hyperkalemia and worsening renal function in patients treated with spironolactone. These did not have significant long-term effects in this highly monitored study population, but these findings are important when we think about using this drug in clinical practice. Thank you.
Thanks, Dr. Redfield, for that excellent discussion of the TOPCAT trial. Finally, I'll turn to Dr. Marco Metra, who's going to talk to us about a trial that was run out of the NHLBI Heart Failure Network called the ROSE AHF trial. Dr. Metra.
Yes, thank you for the invitation. The ROSE trial is the last achievement of the NHLBI network on heart failure, which is a network dedicated and devoted to the assessment of medical treatment in heart failure. The ROSE trial was designed to test the hypothesis that two agents administered at doses acting selectively in the kidney, at least on the basis of mechanistic studies, could improve congestion and or renal function in patients admitted for acute decompensated heart failure. The two drugs are two drugs which are commonly used in patients with acute heart failure, and they are low doses of dopamine or nesiritide. Also, this one administered at low doses, which should have a selective action on the kidneys. Patients have been randomized to placebo or to a low-dose dopamine or low-dose nesiritide administered on top of concomitant treatment. The two co-primary endpoints were related respectively on decongestion, and this was the urine volume at 72 hours after randomization, and the second co-primary endpoint was related to renal function, and was the change in serum cystatin C levels. Then there were a number of secondary endpoints assessed and adverse events. The trial failed to show any beneficial effect on the co-primary endpoints and the secondary endpoints. There was neither nesiritide nor dopamine had any effect on urine volume or the changes in serum cystatin C compared with placebo, and also the other secondary endpoints related to decongestion, symptoms, renal function, and outcomes at 2 months and at 180 days after randomization. They were not different in the patients assigned to placebo compared to those assigned to dopamine or nesiritide. There were differences in side effects, adverse events. Actually, dopamine compared with placebo was associated with a lower incidence of hypotension, 1% versus 10%, and but with a tendency P 0.07 to a larger, greater incidence of tachycardia. In contrast, nesiritide was associated with a greater incidence of hypotension. Subgroup analysis showed some hypothesis-generating results namely when patients were subdivided according to the ejection fraction. And dopamine was worse than placebo in the patients with a preserved ejection fraction, and had a better effect than placebo in the patients with a low ejection fraction. And again, nesiritide had a better effect in the patients. There was a tendency with nesiritide to a better effect in the patients with preserved ejection fraction. But the numbers were too low to draw final conclusions. So what can we conclude with this trial? First of all, surely most of we lack evidence for many drugs that we administer in clinical practice in patients with acute heart failure. Second, it's surely difficult to show a beneficial effect in a setting of acute heart failure, and the selectivity of these agents with respect to renal function is not that high, because the adverse events were not related to effects on the kidney. And surely there is still room for improvement with new drugs acting selectively on the kidneys, and to improve the congestion relief in the patients with acute heart failure.
Thank you, Dr. Metra, and I'd like to thank all the panelists today for attending the session and discussing with us these 4 remarkably important trials in heart failure presented today at the American Heart Association Session 2013 in Dallas, Texas. Thank you very much.